Tengo el gusto de presentar al doctor Alejandro Alfaro Goldaracena. Él es cirujano general por el Instituto Nacional de Ciencias Médicas y Nutrición Salvador Subirán y cirujano oncólogo por el Instituto Nacional de Cancerología. Actualmente es médico adscrito al servicio de la Dirección de Cirugía General del Instituto Nacional de Nutrición. El doctor Alfaro nos va a hablar acerca de la clasificación de los tumores de la unión esófago-gástrica, que desde su clasificación vienen las controversias, Siewert y más allá. Doctor Alfaro, por favor.
Muy bien. Muy buenos días. Muchas gracias, doctor Medina, por la presentación. Muchas gracias por la invitación. Soy Alejandro Alfaro, cirujano oncólogo del Instituto Nacional de Nutrición. Y empezando el módulo de cáncer de unión esofágo-gástrica, platicaremos con relación a las controversias en la clasificación del cáncer de la unión esofágo-gástrica, Siewert y más allá. Sin conflictos de interés, empezamos platicando que se trata de una enfermedad que tanto por cuestión de clasificación como por cuestión de tratamiento es difícil. Se trata de una enfermedad de una región anatómica, es una enfermedad zonal, no es específica a un órgano. Tenemos que traslapar evidencia proveniente de estudios que de forma inicial al menos eran para cáncer de esófago y cáncer gástrico. Hay diferentes backgrounds de entrenamiento en las personas que manejan o en los cirujanos que manejamos este tipo de patologías, como cirujanos gastrointestinales, oncólogos, cirujanos de tórax. Tiene un drenaje linfático tanto mediastinal como abdominal y se suele diagnosticar en estadios clínicos.
Mediastinal and abdominal lymph drain, and it is discovered in advanced stages with overall survival 20% at 5 years in the best series. Regarding epidemiology, this is the solid tumor that has increased most for the last years from the 50s up to date. The transition has to do with risk factors such as obesity and gastroesophageal reflux. In series or reports of the Western countries particularly, it's been centralizing. Although this has not increased in the Eastern countries, gastric cancer is now also seen in the proximal region. Regarding the risk factors, we know that smoking, obesity, and particularly reflux account for 70% of the risk factors, while GEJ cancer initially was classified as a cancer having as a risk factor Helicobacter pylori and reflux. We have seen that this has been reversed over time, and today the main or the leading trigger, the leading risk factor that we see exacerbated by smoking and obesity is gastroesophageal reflux. Also, we see that such progression towards the barbed esophagus in a transition of normal epithelium to dysplasia carcinoma, that has to do with the triggering factors. As we will see later, it has to do with this molecular classification that will give us more information, not just the anatomical location. WHO defines as those lesions in the gastroesophageal junction, irrespective of the size of the lesion. And we are not even in agreement when we speak about the definition of the gastroesophageal junction. Anatomically, as his angle or the most distal portion of the lower gastroesophageal junction, or PRAIC criteria as the proximal margin of the gastric folds or distal margin of the longitudinal margins of the esophagus. And based on pathology, it is this mucosa, the oxidic mucosa. While these definitions do not match the proximal margin of the gastric mucosa folds, it is 2 centimeters proximal from the pathological limit. And the Z line, this is the line that is visible endoscopically, which is 3 millimeters proximal from the anatomical limit. Looking for classifications initially by ICD, through sites or subsites. This is a topographic classification. This is based on 1,000 patients by Liverpool. Then Ellis et al. Proposed initially these classifications that didn't succeed. They were just mere proposals up until 1987. The German group by Dr. Siebert in the International Association of Esophageal Diseases and the Gastric Cancer Society approved these classifications last decade. When we speak about TNM, all the way to the 6th edition, no mention was made of gastroesophageal junction cancer. It is after the creation of a collaboration group for the study of esophagus in 2006 that 13 institutions from different countries come together with almost 5,000 esophagestomies, and we arrive at the classification for the lesions in the gastroesophageal junction. When we speak about the Siebert classification, point 0 or the proximal point where there's the convergence of the gastric longitudinal folds, it is where we will take the reference 1 centimeter up, 2 centimeters down, and 5 centimeters proximally and distally. This is a classification that we should mention. This is a morphological classification, topological classification. This is how this was born. This was not a proposal for treatment. This is not a biological classification. This is topographic classification and anatomical classification. Through endoscopy to make an anterograde and retrograde assessment, radiological, also through a CAT scan. And when making the operational definition, this needs to be confirmed interop. Type 1, 1 centimeter to 5 centimeters under the junction. Type 2, this is the one that causes more problems, 1 centimeter up and down. Type 3, more distally, 5 centimeters. Once we have this classification, we then start to be able to see the difference among the different types. In the first analysis made of these type of patients, we can see that it is more frequent. Type 1 is more frequent in men. This is esophagus cancer. Intestinal metaplasia or Barrett's esophagus is seen in patients with lesions type 1, 10% lesion 2, 2% or almost nothing in type 3. When we speak about the histological classification of intestinal or diffuse type 1, 81%, intestinal carcinomas, and type 2 and type 3, around 60% diffuse, 70% differentiation. When we speak about lymph drain, this is circumferential, unidirectional, bidirectional. These are the adenopathies that we have in that region. These are mediastinal, paratracheal, inferior paratracheal, and also when we speak about perigastric, iliac, and the splenic. So this is a distribution. This is what we need to mention. In the lower third, as we see, most of the lower third of the esophagus, the greatest percentage will be at the abdominal level, 30%, as well as in the lower mediastinal level, 25%, lower mediastinal, mid-mediastinal, under carina, 17%. When we speak about lymph nodes, we see that in those lesions, in Siebert 2, these will be high lymph node lesions with levels 1, 2, 3, and 7, moderate and very low when we speak about the body of the stomach. The prognosis. Type 3 lesions have worse prognosis in overall survival, maybe due to the predisposition to distant metastasis. What are the drawbacks? Stenosis do not allow us to make the proper assessment. There's a 70% accuracy on endoscopies, 72% through CAT scan.
De un estudio que
study, those lesions cannot be assessed because we don't see the landmarks. Point 0, which is part of the definition from which we consider the reference. This is not mentioned in the initial publication. It is impossible to make the assessment, and the asterisks in the interop assessment in minimally invasive techniques cannot be carried out so therefore the surgical planning is important. Niche classification, the center is 2 centimeters, and what are the therapeutic implications? We know that those lesions that are Sievert 1, in those lesions, there's no controversy. They are managed as esophagus cancer, type 3 as gastric cancer. What happens with lesions type 2? We know that in the evolution of the management of gastroesophageal junction, Loringer, what he tried was to reduce surgical morbidity by using the transhiatal approach. This and block dissections with Skinner and Akiyama, and then minimal invasive techniques. All of these was based on functional units or multidisciplinary teams. What changes were found in the 8th edition? The reference point of the lesion is not the upper margin, but the epicenter. Those lesions with epicenters no larger than 2 centimeters in the cardias are esophageal adenocarcinomas, and when it goes beyond 2 centimeters, these are considered as gastric cancer. So along those lines, we see more patients with esophageal cancer. Perhaps this therapy will make us have better margins with esophagectomies, with the lower recurrence rates, and those upper anastomosis of the jejunal esophagus and the jejunum have a higher leak rates. When we talk about the genetic signature of the portion, the lesion, when trying to differentiate the lesion, this doesn't really have to do with the anatomical location, but this is something that we will see after the 9th edition. And this will show the biological behavior of all of these tumors and the potential treatment. We are at a point at which part of the controversies is whether we go up or down regarding surgical treatment. We must understand the differences between gastric, esophageal, and GEJ cancer, which is a different disease with different etiology and physiopathology. And we're just waiting to see the protocol, which will be the first multinational prospective randomized study comparing those lesions of the gastroesophageal junctions, Sievert type 2, and transthoracic, transhiatal gastric procedure with the different procedures. Thank you very much.
Muchas gracias, doctor Alfaro.
Thank you, Dr. Alfaro, for your presentation. Next, we will have online Dr. Mitchell Posner. Dr. Posner is an oncology surgeon, chair of oncologic surgery at Chicago University, past president of the Society of Surgical Oncology. And Dr. Posner will talk to us about controversies in the surgical management of gastroesophageal junction cancer.
Okay. Muchas gracias, Professor Medina Franco and Cárdenas Roque. I also want to thank Professor Martinez Said and Medina Franco for the kind invitation. I wish I could be with you in Mexico, but this is the second best. I'd like to talk to you about the controversies in the surgical management of gastroesophageal junction cancer. This is our campus here at the University of Chicago, and you can see our city in Lake Michigan in the at the top. What we're going to focus on today is the gastroesophageal junction. There has been a lot written about specifically 10 centimeters of the esophagus and stomach, more written than probably needs to be. But we will review what the controversies are. And I will tell you that many of the controversies I'll talk about also apply to gastric cancer in general. And I'm going to start with that as a lead into focusing specifically on gastroesophageal junction cancer. A few years ago, the American College of Surgeons and the Alliance Cooperative Cancer Trials Group decided that there was a need to standardize cancer surgery, just like we standardize medical oncology and chemotherapy and radiation oncology in clinical trials, and in terms of standardizing care across the board to improve outcomes. And our focus in one of these was on the stomach, which I was privileged to participate in. And what we did was look at specific issues and key questions in the management of gastric cancer and gastroesophageal junction cancer. And what we did is look at all of the available data, all of the available research, and we're able to decide and make recommendations on all of these issues that you see here, as well as to assess the quality of the evidence that we made our recommendations on. So we'll talk about intraoperative staging, resection of the primary tumor, surgical margins, lymphadenectomy, and reconstruction of the GI tract. The key questions, in addition, that we thought we needed to answer was the extent of lymph node dissection. What is in fact the optimal extent of lymph node dissection? And secondly, for GE junction cancers, what's best, an esophageal or a gastric surgical approach, which I will get to in a little bit. In terms of staging, we looked at staging laparoscopy, recognizing the sensitivity and specificity to pick up occult metastatic disease that occurs in approximately 30% of patients, and also the value of peritoneal lavage. Recommendation was that staging laparoscopy should be routinely performed for locally advanced tumors prior to gastrectomy, that there's low yield for early stage disease, and this was based, unfortunately, on retrospective studies, but it was a strong recommendation, recognizing that the quality of the evidence was only moderate. What about resection of the primary tumor? Again, a controversy, partial versus total gastrectomy. Of course, that depends on the tumor location. Partial and total have been shown to have comparable outcomes in terms of survival. We also were addressing the resection of adjacent organs and whether bursectomy was in fact necessary. And our recommendation was that partial gastrectomy for cancers of the middle third and distal third of the stomach was appropriate, total gastrectomy for cancers of the proximal third, and removal of adjacent organs when needed to decrease local recurrence, and that resection of the omental bursa is no longer considered standard of care. There were some prospective and randomized clinical trials. This was a strong recommendation, but again, only moderate quality evidence is available. What about a minimally invasive surgical approach? Here there is really good data. We know that from the Korean study here, class 01, that for distal for distal tumors that are early, that when you look at open approach versus laparoscopic approach, long-term survival is exactly the same as you can see here, both overall survival and cancer-specific survival. The class 02 study, again from Korea, looked at locally advanced gastric cancer, and again, in the distal portion of the stomach. And again, the long-term outcomes in terms of relapse-free survival was exactly the same, whether you had an open approach or an MIS approach. This was confirmed by a trial done in China, again, looking at the locally advanced gastric cancer, and again, comparing open distal gastrectomy to laparoscopic. 3-year disease-free survival, again, was exactly the same. Now, these are all studies done in East Asia. What about in the Western part of the world? Again, we're not so clear, and we have not had extensive trials to look at this, but there's one trial from the Netherlands that looked at this. And again, this is early data looking at length of stay, which interestingly was no different between the open and MIS approach. And again, this is for locally advanced gastric cancer, which is what we see in the Western world. We don't see early gastric cancer very often. Operative time was prolonged for MIS. Blood loss was more for the open procedure, and the rest of the variables are exactly the same, as you can see here. So I think the word is still out in terms of patients in the Western part of the world in gastric cancer. We'll hopefully have survival data from this study in the near future. So in terms of MIS gastrectomy, we recommend that minimally invasive surgery is a suitable alternative to open surgery. not just limited to early and distal gastric cancer. Minimally invasive for advanced gastric cancer that requires a total gastrectomy should be based on the surgeon's expertise in ensuring that that is adequate. Robotic surgery does not appear to be inferior to a laparoscopic approach. Again, this is based on East Asian studies that are randomized and large retrospective studies, a strong recommendation, and the quality of the evidence was considered very high. Assessment of surgical margins. For distal tumors, it's always thought about having one at least greater than 3 centimeters. Some would say 5 centimeters. For proximal tumors, it's unclear, and whether that margin distance is related to local recurrence or overall survival. So again, we explored the data and we recommended that a microscopically negative resection margin, of course, should be sought, that for early stage distal cancer, it should be greater than or equal to 3 centimeters. For late stage distal and proximal, it's basically get a margin, whatever you can. And then the question comes up about frozen sections and whether a positive margin re-resection should be performed. But we concluded that actually that probably does not change the outcome because a positive resection margin on frozen frequently suggests aggressive biologic behavior. This is based on retrospective evidence only. The quality of the evidence is low, but the recommendation was strong. In terms of assessing the proximal margin, the really question is the risk of local recurrence outweigh that of distant recurrence? Again, this is the issue of the biology of the tumor. And the fact is, if you think that the risk of local recurrence is greater, then a frozen section should be entertained. And if it's positive, consider whether the additional morbidity of getting another margin is worth it to the patient. How about when you have a microscopic positive margin on the final pathology? And again, you must weigh the risk of a local regional recurrence and that of distant recurrence. And if you believe that that risk is greater, then yes, you could consider re-resection, but in general, that is unlikely to change outcome. Regional lymphadenectomy, agree that at least, our recommendation was at least 16 regional lymph nodes should be removed, and a D2 dissection is the minimum lymph node dissection that would enable obtaining those 16 regional nodes. This is based on prospective trials and meta-analyses. It's a strong recommendation based on high quality evidence. What about reconstruction of the GI tract? After total gastrectomy, it's either a Roux-en-Y or with or without a jejunal pouch. And that you can see here. Here's a straight esophago-jejunal anastomosis with no pouch versus a pouch. And whether there's value to a bowel interposition also after total gastrectomy. Our recommendation here was that esophago-jejunostomy with Roux-en-Y is recommended after total gastrectomy. The addition of jejunal pouch is controversial, but it may in fact improve quality of life and should be considered. Available data does not support a clear benefit to bowel interposition techniques over Roux-en-Y reconstruction after total gastrectomy. These are based on small randomized controlled clinical trials and meta-analyses. It's a strong recommendation, again, with moderate quality evidence. What about after proximal gastrectomy? Again, we have two options, a jejunal interposition versus a direct esophago-gastrostomy. The recommendation here is that a direct esophago-gastrostomy is not recommended because it's associated with severe postoperative reflux and impacts quality of life. Current evidence does not permit the formulation of evidence-based recommendations for how we reconstruct. And I think we really have to tailor this to individual patients. In some instances, I certainly have done a direct esophago-gastroscopy because I think it's the safest thing for a patient who may be elderly and cannot get through a more extensive operation. Again, this is a weak recommendation and only moderate quality evidence. And then we had these key questions. The first key question was the extent of lymph node dissection and the optimal indicators for morbidity, mortality, and long-term outcomes. We stated that a D2 lymph node dissection preserving the pancreas and spleen should be considered standard. Extended lymph node dissection beyond D2 should not be routinely performed because it does not improve outcomes and leads to increased morbidity. For early stage tumors with poor functional status or significant comorbidities, a less than D2 dissection, a D1 or D1 plus, can be considered. And here getting to, again, specifically focusing on the GE junction, does an esophageal or a gastric surgical approach offer better outcomes? I think we just heard about the classification. Again, for type 1 and type 2 Siewert lesions, these are both considered esophageal. Type 3 is now considered by the TNM-8 to be gastric. So what was our recommendation here? That the proximal and distal extent of the tumor really influences our choice of operation. Overall survival appears comparable between esophagectomy and gastrectomy. And there's no statistically significant difference between R0 resection, lymph node yield, and perioperative results, and I'll show you the data in a moment, between esophagectomy and gastrectomy. Type 1 cancers should be treated with esophagectomy. Type 3 should be treated with some form of an extended gastrectomy, whether it be total or proximal. And for type 2 cancers, either an esophageal or gastric surgical approach is reasonable. Looking specifically at Siewert type 2 studies, this is from the National Cancer Database, mining that database. What you can see is that for type 2, that there is a strong preponderance of esophagectomy over of gastrectomy over esophagectomy. And this is up to 2016. So an interesting look at this, even though we believe these are esophageal tumors, many are approached just from below with a gastrectomy. When you compare esophagectomy, however, to gastrectomy, what you see, and this is 10,000 patients, 1,000 of which underwent an esophagectomy, the overall survival appears to be improved in Siewert type 2 when you perform an esophagectomy. And I will tell you, if the patient can handle an esophagectomy, I favor doing an esophagectomy over a gastrectomy for type 2, if in fact we can figure out that it's truly type 2 when we're there in the operating room. When you look at GE junction, again, and this does not specifically cull out Siewert type 1, 2, or 3, but the GE junction in general, when you look at all overall survival, and again, this is a study, study from the Netherlands, mining their own database. There's no difference in overall survival between esophagectomy and gastrectomy. When you look at it with regard to the differences here, again, yellow and blue here, esophagectomy and gastrectomy are exactly the same. The difference here is that these patients here had chemotherapy, neoadjuvant chemotherapy, or neoadjuvant chemoradiotherapy. And when you compare between whether it's an esophagectomy or a gastrectomy, there is clearly value to adding preoperative chemo or chemoradiotherapy in these patients. This is another study that will be published soon in the Annals of Surgery. This is looking at survey data prospectively in patients with GE junction cancers, again in the Netherlands. They collect data in a prospective manner, then look at it retrospectively. Again, no difference between total gastrectomy and esophagectomy with regard to 3-year overall survival, and that includes with esophagectomy a transthoracic approach or a transhiatal approach. I think this study is really the most informative study because it is a prospective multi-center trial from Japan comparing total gastrectomy to proximal gastrectomy. People have been very concerned about doing a proximal gastrectomy, but this is actually looking at prospective data and comparing the two. It's not randomized, but it is prospective, and I think really provides some interesting insights. And what they showed is the solid lines are proximal gastrectomy, the dotted lines are total gastrectomy. In terms of body weight, which was the primary endpoint here, the fact is that proximal gastrectomy was better than a total gastrectomy. The same is true for nutritional parameters, looking at hemoglobin. They were the same for serum albumin. So the idea that proximal gastrectomy is necessarily a bad approach should not be dogma. And in fact, I think we need to relook at it, and I'll show you why. When you look at overall survival, there's absolutely no difference looking at this prospective trial between proximal gastrectomy and a total gastrectomy. When you then look at short-term complications, and the one we worry about is reflux esophagitis, What you will see is that when you do a proximal gastrectomy here on the right compared to a total gastrectomy, there's more reflux esophagitis. But if you actually look at severe reflux, it's exactly the same. There's no statistical difference. Again, going against the dogma that a proximal gastrectomy is a bad operation. And I think the reason is that we do have another reconstructive technique that may have significant value, and that's called double tract reconstruction, where you do a Roux-en-Y between the jejunum and the esophagus, but then about 10 to 12 centimeters below that, the proximal stomach is anastomosed to the jejunum. And then when you look again in this prospective trial and look at the data, I think it's very telling. When you look at a proximal gastrectomy with a direct esophageal gastrectomy, you again see a significant amount of reflux esophagitis. However, when you do this double tract reconstruction and compare it to a total gastrectomy, the degree of a reflux esophagitis is exactly the same. So I hope I provided you with some insight into not only many of the people who are dealing with this tumor directly in the United States are thinking about it, and some data to direct us in terms of how we manage esophageal junction cancer going into the future. Again, muchas gracias, and I really appreciate having me participate in this wonderful forum. Thank you.
Yeah, okay. Buenos días en México.
Good morning in Mexico. Thank you to the I.M.S.S for inviting me to talk with Dr. Posner and Dr. Christian Flores and Dr. Alfaro about controversies in the medical management of esophago-gastric junction. I am a doctor in the Instituto Nacional de Ciencias Médicas y Nutrición. I'm going to talk about controversies of the medical treatment of gastroesophageal junction cancer. As Dr. Posner said, treating the gastroesophageal junction tumors, well, leaves us with a decision to us medical oncologists. Where do we get the literature? Do we go to the esophageal cancer or the stomach cancer literature? Our treatment should be just chemotherapy, or should we add radiotherapy to our treatment regimen? Should we give neoadjuvant and perioperative treatment, or should we give post-op treatment? So it depends on the type of histology, if the patient has adenocarcinoma, or if the case of the squamous junction is different, and should they be treated with esophagectomy or with a gastrectomy? In the world of medical oncology, I'm going to start a little bit, with the end. After a lot of debate and discussion of the strategies based on chemotherapy or chemo and radiotherapy, there's a recent paper that compares prospectively and randomly the two most based on the cross. I'm so sorry. It's the screen is freezing. In patients with esophageal cancer and the gastroesophageal junction and of adenocarcinoma. So this trial did not show a difference in survival, and therefore we can go back to look at the strategies to follow which one we will use to treat these patients. At least this is a contemporary trial. These randomized patients, well, it wasn't really easy to show that there was an improved survival with these strategies. So if we go back in time, it's always good to know that these strategies come from an entire history of the world of neoadjuvant chemotherapy and also radiotherapy in the literature of patients with esophageal cancer. In the meta-analysis published about 10 years ago, we can see how the history that started in 1982 with the first trials based on chemotherapy, and 1983 for studies based on chemo and radiotherapy. So there are multiple strategies were assessed, and unfortunately, not all strategies showed or were established as standards of treatment. Here you can see in the last line that the trial that I'm going to discuss, the CROSS, a few well-designed studies with the sufficient power and established chemo and radiotherapy as a standard of treatment. And in the world of chemotherapy, we can see that the trials I will discuss are not included, but chemotherapy was or has been studied in the past, and these show a benefit in the effect with this standard of treatment, which is cisplatin. And in these strategies, these are the winners in the different areas. The CROSS trial, it's a reference trial for neoadjuvant chemo and radiotherapy. It showed an overall survival of 48.6 months and 47 at 5 years, and the preoperative chemo, known as FLOT4, the overall survival is 40 months when analyzed separately and not comparatively. Let's look at the benefits or the merits of neoadjuvant chemo and radiotherapy in patients with gastroesophageal junction cancer. So the CROSS trial is a randomized trial with hundreds of patients. 368 were randomized 1-to-1. The importance of the CROSS trial is to see that the histology wasn't just adenocarcinoma. 23% had squamous histology, and basically these were esophageal tumors and of the junction. Mostly, and 65% of the patients had positive lymph nodes. The physical performance for this clinical trial was, or 81%, had an excellent performance status. The study was stratified by histology and by the physical performance, and treatment is the neoadjuvant administration of concomitant chemo and radiotherapy. Unlike the trials I presented, this one combined taxane and platinum in a weekly regimen, and the radiotherapy dose that was unlike the radiotherapy based on cisplatin in very high doses. At least in American trials, the dose is 50.4 grays in 5.5 weeks. Patients were treated, and the ratio of transhiatal esophagectomy was in these two groups. The primary outcome and the overall survival were better for patients who received neoadjuvant treatment with chemo and radiotherapy. And this is the odds ratio, 0.67. And there was an absolute benefit for those who were treated with the cancer treatment, 14%. And the risk ratio was 0.67, and the curves separated and remained separate for a long time. So we have the update of this trial with a minimum follow-up of 5 years and a mean of 80 months. And the benefit is maintained for this treatment strategy. And one of the criticisms to the trial is that the benefit was for the patients who had a squamous histology. And this is the risk ratio, 0.48 for those who had a squamous histology, and 0.63 for those who had an adenocarcinoma histology. However, the difference between adenocarcinoma treated with chemo and radio versus operated is statistically significant. It doesn't depend just on the squamous histology. It is applied to both histologies. So the researchers presented a subgroup analysis, and graphically we can see that adenocarcinoma had proportionally lower benefit than the squamous histology in patients with negative lymph nodes, Well, these were subgroup analyses. In terms of chemo and radio, the patients treated with chemo and radiotherapy, they could benefit in terms of decreasing the local regional benefit. The researchers gave an update in the publication of 2015 showing that this is not the case. Treatment with chemo and radiotherapy decreases the local regional recurrence, and the risk ratio is 0.45, but it also decreases the distant recurrence with a risk ratio of 0.63. Compared to those treated only with surgery, the local regional recurrence was 38%, and compared to 22% for patients who had received treatment with radiotherapy, but the distant recurrence decreased from 48 to 39% with the same treatment. The strategy, the comparative strategy, or the perioperative chemotherapy with no radiotherapy is a strategy that started not in the FLOT, but in others. In other studies, we have the French trial that had used this in 224 patients, mainly the gastroesophageal junction with a benefit for radiotherapy compared to only surgery. And the regimen used was 5-FU and cisplatin. The British trial known as the MAGIC, interestingly, used 3 drugs, a combination of 3 drugs, including anthracyclines and perioperative therapy. Although the study had a minority of gastroesophageal junction patients, this regimen was used for patients treated with the gastroesophageal junction tumors. How is the FLOT trial different? Well, it's different because it doesn't compare with surgery only. Once the perioperative therapy was the treatment standard based on previous trials, so the comparator was SF and the modification SX instead of 5-FU. Other differences we're seeing here, the characteristics of patients. The mean age was 62, good, also good performance status, and there was a balance between the patients with the junction and stomach tumors, unlike the original MAGIC, which was basically stomach. 44% were junction tumors, C-word 2-3. So there was a good balance and better application of results in junction tumors. The difference with cross was in this one, 81% of patients had positive lymph nodes, and it included patients with different adverse prognosis parameters like diffuse histology in 27% of cases, and 300 with lymph nodes. So treatment was randomized to 3 drugs, including docetaxel, oxaliplatin, or epirubicin, 50 milligrams, and cisplatin, and 5-FU. The FLOT 4 that compared to perioperative chemos, this is the result of the overall survival. Patients treated with taxanes had a decrease in the risk of death of 0.77. The mean survival was 50 months for the FLOT compared to 35 months for the standard group, which was SF. 56% of patients had junction tumors, and this is a subgroup analysis showing that patients also have the same benefit if they're treated from stomach tumors or junction tumors, or if they are at risk. This is 0.76 and 0.77. So it says that the FLOT 4 is a benefit both for patients with a primary in the stomach and a primary in the gastroesophageal junction. So these are independent trials. One was the chemo and radiotherapy compared to surgery. The FLOT4 included 2 chemos, and these are positive trials. How do clinicians decide between 2 strategies that are valuable in these patients? Well, it's not simple. We can look for comparisons in the studies, and we see that the patients included in both trials had a similar median age, 60 years. Both trials selected patients based on the good performance status. Patients had positive lymph nodes in the pre-op stage, but mostly the patients had positive lymph nodes, and most of them were T3, and the cross trial didn't include patients with T4 tumors, and a low proportion of the pre-op chemotherapy included patients with T4 tumors. How are the resection rates compared? Well, both strategies improve the resection, the R0 resection trials. In case of chemo and radiotherapy, the R0 increased or decreased from 66 to 59, and then from 77 to 90 with chemotherapy. The complete pathological responses, there's 29% for the cross, and with squamous histology, and these responses were in patients with adenocarcinoma. The FLOT4 regimen had a complete pathological response of 16%, 23% in the bowel. Both trials showed that non-adjuvant strategies didn't interfere with surgical outcomes. Post-op events were similar in the group of patients treated with chemo and radiotherapy, neoadjuvant therapy versus surgery in the cross. And the 2 chemotherapy regimens did not modify the post-op events. The mortality in both was close to 2%, and the adverse events differed in those patients who received chemo and radio with toxicity that was low, and the chemotherapy trials, the chemotherapy regimens differed in the neuropathy, diarrhea, and diarrhea rates. So clinicians want to determine which of the 2 strategies is associated to better outcomes comparatively. There are several trials with this purpose to define the best strategy, if radiotherapy should be included or not in the treatment of patients with esophageal and gastroesophageal junction. And as I said, that this is a result of this trial. This was done in Ireland that randomized patients to the perioperative chemotherapy. When the trial began, the reference regimen, the SF, there was an amendment, and where patients could be treated with the most current regimen with a FLOT and with a chemoradiotherapy that has shown this survival advantage with the cross regimen. Originally, the chemoradiotherapy could be better than the perioperative regimen, but it was amended afterwards. This is the randomized trial. We can see that patients were more than 50% had positive lymph nodes. The most used surgery was the transthoracic esophagectomy. And although the parameters, the response parameters could be evaluated during surgery and were favorable for patients who had received chemo and radiotherapy in terms of a complete pathological response, a better R0 resection rate, a better major pathological response. The truth is that patients' survival did not change after the second interim analysis. It said that although follow-up will continue, it is possible that results won't change. So the criticism to the trial indicate that the compared regimens are not contemporary. Clearly, the FLOT regimen is better than the one used in 80% of patients in the trial, and that perhaps didn't show the true benefit of perioperative chemotherapy over chemo and radiotherapy. However, everything moves. So the regimens are probably not contemporary. In the FLOT trial, there may be a modification in terms of its efficacy. The results of the FLOT 7 trial were published recently in the trial called I.M.S.S. In this phase 2 trial, adding rarucirumab to the FLOT 4 cycles and post-surgery, this could be associated to better response rates in the R0 resection. So this is R0 resection increased from 87 to 97% when using the FLOT and rarucirumab. So we have to look at or wait for phase 3 to see if these responses are associated to better survival. The chemoradiotherapy regimen has improved. This is the result of the Checkmate 577, published recently in the New England Journal of Medicine, showing that patients treated with chemo and neoadjuvant chemo and radiotherapy with adenocarcinoma or squamous cell carcinoma with no pathological response benefited from adjuvant nivolumab, regardless of the PDL1 expression status. After 794 randomized patients, the primary endpoint of improving the survival was reached with a risk ratio for recurrence of or death of 0.69 and a median survival of 22 months for patients treated with nivolumab, adjuvant nivolumab, compared to those treated with placebo. And the benefit was maintained in patients who had adenocarcinoma and squamous cell histology. Is there a better regimen to assess chemotherapy in these patients? Well, the reference trial contemplates paclitaxel and carboplatin. Historically, it is not the regimen that was most researched. They used fluoropyrimidines and platinums, and it's interesting, though, to see how this indirect comparison between the radiosensitization of taxol carbo and the other regimen used, which is 5-FU or oxaliplatin, like in the FOLFOX, showed in this phase 2 trial that patients who responded to FOLFOX that continued chemo and radio with FOLFOX probably had better survival than those who started treatment with paclitaxel and carboplatin. As you can see in this chart, the winning group in the red line is for those patients who were treated with FOLFOX and were responders, compared to the blue line, the patients who had been treated with paclitaxel and carboplatin and were responders based on the PET. And there are trials to come, of course. The ESOPEC trial is a German trial that wants to update the response of whether it is better to use chemo and radio, neoadjuvant chemo and radio, or perioperative chemotherapy. All patients with this chemotherapy arm will be treated with a FLOT regimen, like in the study that I mentioned. There's another trial called Top Gear. Perhaps there really isn't a need to decide between a treatment group or another, a perioperative strategy or a chemo strategy, but rather, combine the strategies, and that will be defined in this randomized trial. So it's interesting to see the immunotherapy added to treatment regimens, the perioperative regimens, That will be studied in the keynote trial. So in conclusion, for the treatment of gastroesophageal junction tumors, there are two strategies for multimodal treatment of the junction tumors. These have been developed as independent platforms to evolve treatments. As we saw, the evolution of chemotherapy, it is complemented with the benefits of adjuvant nivolumab, and it's possible that FLOT, and we're about to see whether to include ramucirumab that improves the treatment strategy, the perioperative strategy. Future trials will define optimal strategies, better radiosensitization regimens, and the role of chemotherapy. Thank you. Well, and to continue with our assessment of the treatment and controversies, I want to introduce Dr. Cristian Flores Balcázar. She's a radio-oncologist from the Instituto Nacional de Ciencias Médicas Salvador Subirán. Welcome, doctor. Go ahead.
Thank you. First off, I would like to thank the organizing committee. And as we saw in the last two talks, we can observe that the cancer in the gastroesophageal junction, esophageal cancer, and stomach cancer have increased their incidence as compared to the 70s. We know that for most tumors, surgery is the gold standard. However, in this particular case, we know that prognosis of tumors in the GEJ is poor, not only because there is a local regional recurrence, but also systemic recurrence. And with surgery, it is likely that we will reach a survival of 30%. Therefore, we use chemotherapy or chemoradiotherapy in order to improve the clinical outcomes and the surgical outcomes. However, there are some controversies, as the previous speakers said. At least in radiation therapy, we have many unanswered questions, like the type of neoadjuvant treatment. This is chemotherapy alone or chemotherapy with radiation therapy, the impact of the radiation dose and the implications that this may have if patients undergo surgery, and also adjuvant treatment after surgery. Regarding neoadjuvant therapy in GEJ tumors, we know this is difficult because of the type of location of these tumors. Not only are they included in the esophageal tumors, but also in clinical trials of gastric tumors. So therefore, there are no specific studies on this entity, so the inclusion criteria are very variable. We also know that there are some randomized clinical trials that have developed the way we treat patients along the years. With Dr. Witzel, we looked at the MAGIC Accord studies, and we know the advantages of one regimen over other. Those advantages are not very clear. It is a case of the clinical trial. This is a pivotal study. Based on this, we know that patients with this type of tumors will benefit from chemotherapy and radiation therapy. There are other things we need to point out. Dr. Witzel mentioned the benefit of chemoradiation therapy was lower in adenocarcinomas, even if we have a benefit in PFS and overall survival. But something that we can criticize about these trials is that there was not a subgroup analysis so as to know the differences between the treatment of tumors class 1 and class 2. There's also benefit in patients with negative lymph nodes, but not so in patients with positive lymph nodes, in which we would expect more benefit. We also have another study. This is a FLOT, also mentioned by Dr. David Witzel. FLOT does not include treatment with radiation therapy, but 2 cycles of FLOT chemotherapy plus a modified regimen of MAGIC. And patients have more resection rate, RO resection rates. However, there was no such important benefit in patients that received these treatments, particularly in the gastroesophageal junction tumors. We can say, therefore, that chemotherapy in these cases is better in patients with gastroesophageal junction tumors without radiation therapy. And this is important. There are several studies. These are combined studies with treatments dedicated to gastroesophageal tumor, and perhaps non-adjuvant radiation therapy may be valuable, like cross. It has low toxicity profile. Also, radiation therapy allows to reduce the tumor size, but radiation therapy with chemotherapy perhaps could also include a complete pathological response in 1 out of 4 patients. The only important issue that we need to assess is that up until 39% of patients will have a systemic relapse, not local regional relapse. Things like adjuvant chemotherapy and radiation therapy, they both increase the possibility of complete pathological response and R0 resections, but that doesn't necessarily represent a benefit in terms of OS and PFS, because a reduction in the dose perhaps could translate into a lower dose at a systemic level, and this is what perhaps will damage our patients. One of the few studies that were made for patients with gastroesophageal junction tumors is the COVID trial, POET trial. These patients were randomized to chemoradiation surgery, chemoradiation therapy, and surgery. Although there was a trend for better survival with chemoradiation therapy, actually didn't get statistically significant results, although we would seem that patients with negative lymph nodes are the ones that do better with this treatment. What are the trials we have? Also, the ESOFEC using flood versus cross, trying to have the 3-year overall survival, and NEO AGIS comparing flood cross versus cross, where we have a 3-year survival. What matters here is that not only do we need to know the 3-year survival, we also need to know results about toxicity, whether these are cost effective, whether there's post-op morbidity and mortality, or even greater with radiation therapy, or the recurrence patterns of this type of disease. As conclusions of this topic, we can say that not all patients will show response. This is not all of them have a pathological response, and so far we cannot predict what patients will respond to this treatment and which will not, because neoadjuvant therapy reduces the functional reserve of patients by 20%. It is necessary for more prospective clinical trials in order to answer these questions. Therefore, the decision of chemotherapy versus chemoradiation therapy is a controversy in these patients. Regarding the impact of the RT dose and surgical implications, perhaps many of our multidisciplinary sessions, we don't know whether to treat these patients only with 41.4 grays or to take them all the way to 50.4 grays. There are no studies comparing one dose versus the other. What we know of is that there are some studies with important number of patients. These are retrospective studies analyzing the difference between those treated with 40 grays. As you can see this in this Kaplan-Meier curve, patients with 41.4 grays benefit. The overall survival is better than those treated with 50.4 grays. There were no differences in downstaging. There were no differences in the number of complete pathological responses. And these are the patients receiving 50.4 gray as compared to a lower dose. So what do we have regarding adjuvant radiation therapy? For many of us in the multidisciplinary teams, this is a concern to know that a patient that is warned because of a systemic treatment or because of a surgical treatment, and on top of that, we need to make sure whether an adjuvant treatment will be given. In this case, radiation therapy could, although not always. The window froze. Or in case the patient had received cross, no adjuvancy. But what do we know about treatment with radiation therapy? There's not much information about that. This is a review of a national database from the United States, where we can see that patients were included from T0 to 4 with positive lymph nodes. We saw the impact of radiation therapy with or without chemotherapy after esophagus-ectomy. And as we can see, there's a significant difference only in patients with positive lymph nodes. Out of these type of trials, we need to know that patients that have positive margins, those having positive lymph nodes that had not received radiation therapy as part of neoadjuvants, perhaps, although we do not know this for sure, could perhaps benefit from this treatment. As conclusions, we know that in absence of level 1 evidence, multidisciplinary team work must offer adjuvant therapy with radiation therapy based on the number of lymph nodes, tumor grade, or the state of margins. General conclusions, we know that although in clinical trials has been demonstrated that multimodal treatment improves surgical and survival treatments, the best strategy for these tumors is not well defined. It would seem that we have a signal showing that perhaps chemotherapy alone without radiation therapy might be better, although not in all cases. However, the best strategy so far needs to be established in a multidisciplinary way, particularly taking into account the risk factors of each patient. Thank you very much for your attention. All right. Because of time considerations, we will discuss one clinical case. This is a 65-year-old male without inheritance problems for his issue, Wolff-Parkinson-White syndrome, diagnosed at 35, meniscus surgery, and he is on no drugs. The patient comes with progressive dysphagia to solid to fluids of 3 months of evolution, daily epigastric pain with 1 month of evolution that improves when giving PPIs. And he lost 5 kilos since the beginning of the disease. This is 3 months ago. The patient undergoes an endoscopy, and we see an ulcerated lesion in the gastroesophageal junction. Here we can see the retroflexion, the distension towards the stomach, and the epicenter of the lesion is right in the gastroesophageal junction. The lesion is 3 centimeters. A biopsy is taken, well differentiated or poorly differentiated adenocarcinoma. Out of the studies, we will start our discussion with staging studies for this tumor. The staging, including contrast studies, endoscopic ultrasound, CAT scan, PET, CT, and diagnostic laparoscopy. Dr. Alfaro, which of the following studies would you do on this patient? Or would you make all studies on this patient in order to stage the patient? Barium study, we rarely use it. We have endoscopy for screening, and the technicians, endoscopic ultrasound, since this is an ulcerated lesion, that won't help us to look at the invasion. At least we know this is T3. A contrast CAT scan, yes, to look at the locoregional extension. And based on that, a CT PET. And there were 3 lesions. Perhaps they could benefit from diagnostic laparoscopy. If it were 2, that would be a bit controversial. Any opinion, Dr. Posner, specifically controversial? Any opinion, Dr. Posner, specifically about the role of PET scan? Anything you would like to tell us about diagnostic laparoscopy for Siebert 2?
Yes, we in our institution, because all of these patients are in a clinical trial, we do a diagnostic laparoscopy on them, and we've actually found in Siewert type 2's patients with occult peritoneal metastases on peritoneal lavage. So we do it routinely. We also get PET scans routinely as well. So all of the diagnostic modalities you listed there, we incorporate all of them into our management, our diagnosis and management scheme.
Ok,
Right.
continúo.
Let's continue. This is the assessment of this patient. Hemoglobin 12.1. The rest of the labs are within the normal range. Carcinoembryonary antigen rate normal figures, normal range, and this is a CAT scan on the patient. As you can see, it has thickening greater than 5 millimeters. We can see adenopathies on the CAT scan. These are periceliac adenopathies and at least one pre-aortic adenopathy. In this patient in particular, well, I personally agree with Dr. Alfaro. The ultrasound won't give us much more. Endoscopic ultrasound doesn't give us much more. This is indeed a T3 tumor based on endoscopic ultrasound. And so a PET scan was carried out showing primary tumor and adenopathies. There is no evidence of distant metastatic disease. Also, the patient underwent a laparoscopy with no evidence of lesions in the peritoneum, and the peritoneal lavage was reported as negative. And so, in summary, we have this patient that has poorly differentiated adenocarcinoma in the gastroesophageal junction, CBER2. Based on the studies, this is a T3N1M0 with a negative peritoneal lavage. Therefore, we have a patient that has cancer in the gastroesophageal junction. This is locally advanced, not metastatic cancer, and it is resectable from the surgical viewpoint. This is up front. So we start our controversy, and I would like to listen to the surgeon's thoughts. Would some of you conduct surgery, initial surgery, or would you send them to the oncologist for neoadjuvant therapy? Dr. Alfaro, surgery or neoadjuvant therapy? This patient has no indication for initial surgery, thinking about bleeding or other complications. So perhaps this patient needs to be treated through medical oncology, and based on the conditions, we will see the type of neoadjuvant chemotherapy that will be provided to the patient. Dr. Posner, will you take the patient to surgery first, or would you send him to neoadjuvant therapy?
I would not take him to surgery first. I think that would be a mistake. We would treat with either preoperative chemotherapy, neoadjuvant chemotherapy alone, and in some instances, neoadjuvant chemoradiotherapy, although we favor more so now than ever, just preoperative chemotherapy.
Bueno, parece que
It
todos
seems that all surgeons agree on starting with chemotherapy. Dr. Cárdenas, chemotherapy, which one, what the regimen? Based on this data and the evidence that we have today, I think that most medical oncologists need to start. We're no longer fearful about toxicity by flood. So flood, in terms of controversy, we would need to put on the table that today in the country, most institutions, even in some states, we have the times of initiation of radiation therapy in some states of Mexico, even in the private setting. Machines are busy, are full, so we need to know when will we take them to chemotherapy or chemoradiation therapy. That will depend upon the timing. Dr. Witzel, what about the chemotherapy regimen for this patient that has a T3 CBER2 in one? What regimen would you use? I think that, yes, the key would be to assess whether he's eligible for 3 drugs with a flood regimen. We need to see the performance status and the physical characteristics. The performance status is ECOG 0. Well, the patient has dysphagia, but is ECOG 0. Perhaps we would need to make a cardiology assessment just to see taxanes in case of arrhythmia. But up front, I would like to give the most active regimen because it has high risk parameters like positive lymph nodes and poorly differentiated adenocarcinoma. So we want to give them the best by using the flood regimen. A PET scan was carried out on this patient. Dr. Cárdenas with Dr. Witzel conducted a PET scan. Would you conduct another PET scan, PET scan, before taking the patient to surgery? Or PET CT, PET scan before surgery, or shall we change the regimen based on the response by the PET scan or PET CT? Yes, in the most recent study, we saw the metabolic response with the PET scan before and after chemotherapy, and that's not clear based on the prior studies. We don't know whether changing the strategy will improve the outcome. Someone that has chemo resistance to a first regimen, most likely will place this patient in a poor prognosis because that was a randomized phase 2 trial by shifting chemotherapy. Some patients perhaps could reach a complete pathological response, but that was phase 2 trial information. Yes, I would like to ask Dr. Medina, in this patient with progressive dysphagia, this is how these patients start. So what will you do? Would you use a jejunostomy or a feeding tube, or you give them therapy based on the symptoms? In this particular patient that has no aphasia, he has lost weight 5 kilos. He lost 5 kilos. I would wait to see the clinical response to chemotherapy before subjecting the patient to placing a tube or feeding tube on the patient. Perhaps the best strategy here could be a jejunostomy in order not to, just in case, as we will see in controversies, we need to see esophago-gastrectomy, total gastrectomy, what procedure? Christian, any idea about neoadjuvant radiation therapy in this patient? Yes, thank you. Well, first, I would be in favor of the opinion of the surgeon. I would need for the surgeon to tell me whether resection is feasible. And perhaps that would be my decision to start with chemotherapy more than with radiation and chemotherapy. It's better chemotherapy, but if it were N2 and 3, chemo radiation therapy, but this is not the case. This is N1. Okay, we will now continue. All right, so this patient received 4 courses of flood with good tolerance. It has a clinical improvement. This is the dysphagia is solved and the patient can eat normally. No new PET scan was conducted. The new CAT scan shows a T3N0. On CAT scan, we see no more adenopathies as we had seen before on the initial CAT scan. And the next question that I would like to make to my colleagues, to my surgeon colleagues, is what surgery would you carry out on this patient? Total gastrectomy or esophago-gastrectomy? And also, please tell us what approach would you use in case we have all of them available. I know that robots, we don't have many here, but if you had all of these choices, would you use the open laparoscopic robotic approach? Which one would you use and why? Or what would be the advantage? this patient, as we saw, is candidate to gastrectomy or esophago-gastrectomy. In this particular case, I could use either of these two approaches. We have negative margins, and the advantages of minimal invasive surgery are there. This is an advantage as long as we can make the properly oncological surgery, the proper oncological surgery with local control. We need to have enough curve so that lymph node dissections be complete, both at the chest level. If you make esophago-gastrectomy and the abdomen to have the right incisions, studies show equivalence when we talk about oncological outcomes. But we need to perform an oncologically adequate surgery, no matter the approach. Dr. Posner, what are your thoughts about esophago-gastrectomy, gastrectomy with CBER2 and abdominal and intrathoracic, low intrathoracic adenopathies as we saw on the PET scan? What would you do?
Yeah, what we would do is I would not do a total gastrectomy on this patient. I think the patient benefits from an esophagectomy. And I always worry that in these patients with very locally advanced disease like this patient has, we still do not know in this specific instance if an MIS approach, whether it be robotic or laparoscopic, is equivalent to an open approach for locally advanced proximal tumors like this, NGE junction tumors. That being said, I think it depends on the expertise of the surgeon. I would probably do this open, but I would have no objections to someone doing it robotically or MIS or laparoscopic if they had the expertise to do that and be sure they obtained a clear margin.
Bien, este paciente
This patient underwent
total radical.
a radical total gastrectomy, a D2, and esophago-gástrica when wide open. Pathology indicates poorly differentiated adenocarcinoma, sealed ring cells penetrating into the serosa. The margins are free of tumor, 10 out of 38 positive lymph nodes for metastasis. So this is a post-chemotherapy staging. This is a T4A tumor, N3 and M0. For our colleagues from medical oncology and from Christian, after this result, would you continue with chemotherapy, chemoradiation therapy, or would you add, as Dr. Witzel told us, immunotherapy? Dr. Cárdenas, what would you do? What would you do after the surgery? Only to complete flot, or what else would you do? In these cases, we need to ask ourselves in a multidisciplinary way how to proceed. Today, giving immunotherapy, we have seen some results about immunotherapy, but we need to
Imagen, tenemos un
on the
paciente.
image, we have a patient that doesn't seem to respond well to the treatment based on images. So we would need to discuss this with radiology.
¿Agregarías
Dr. Witzel, would you just finish off flot, the 4 post courses of flot, or would you add anything else after this poor result? This is the worst scenario that we have when our best tool doesn't work, doesn't give us the expected result. And we would need to know what the best strategy is based on a clinical trial. Ideally, we would finish the 4 courses of flot because at the end of the day, he had a clinical benefit. He responded to dysphagia. We don't know about lymph nodes. Perhaps we would have found more lymph nodes, but undoubtedly, the patient has poor prognosis. Neoadjuvant therapy would be reduced risk of recurrence in the clinical trial when patients had been treated with chemoradiation therapy. Of course, we believe that it shouldn't be different here, but we don't have the clinical study to give post-perioperative chemotherapy, neoadjuvant therapy. So the standard would be to complete the flot treatment. Unfortunately, this is a poor prognosis case. Christian, radiation therapy, adjuvant radiation therapy in this case, after huge lymph node disease. Well, first, I would assess, together with a multidisciplinary team, the performance status of the patient. And secondly, I would see if they can afford any chemotherapy regimen. In other cases, ideally, would need to give chemoradiation therapy. But there are no prospective trials showing what to do in this case. At least we need to control local problems. I know that we're running out of time, but we have some results from the world showing that these tumors that penetrate the serosa have high risk of recurrence with
¿Cuál es su
peritoneal
opinión?
carcinomatosis. What do you think, Dr. Alfaro, Dr. Posner, Dr. Witzel, about HIPEC as adjuvant therapy in this group of patients? What do you think? These cases that we need to discuss in a functional unit and
Disciplinario, pero aquellos casos que recurren de forma localizada y
local recurrence and remain so, perhaps we could make once in
esos pacientes
metastectomy for patients that have positive
o recurrencia
or early peritoneal recurrences whenever they have certain time free of recurrence.
si se pudiera
In those cases, perhaps we could offer them site debulking and HIPEC, but just in very specific cases that meet such criteria. Adjuvant HIPEC, Dr. Witzel, Dr. Cárdenas. I think that with the evidence that we have, I wouldn't take the patient to HIPEC. And if peritoneal lavage had been positive, you would not have performed surgery on the patient, or would you have given him clot and then you do the lavage? That becomes a good patient to assess the tumor biology. In this case, we would have need to corroborate the response with the neoadjuvant therapy. Perhaps we could repeat cytology, and based on that, Dr. Witzel, I know that you also like HIPEC. So what do you think as adjuvant therapy, or if peritoneal lavage had been positive? Well, as it was said, tumor biology shows that this is a poor prognosis patient. Other than clinical trials, we conducted this strategy, yes, in very specific patients with a good response to neoadjuvant therapy, which was not the case of this patient. The patient, if he has good response to a chemotherapy regimen, yes, a peritoneal lavage, yes, we saw a case, and we were able to rescue the patient, and the patient survived with a perioperative chemotherapy, even in the context of positive peritoneal lavage. But HIPEC is just experimental at this point in time. Due to time considerations, we need to stop. Thank you. Thank you very much to all our speakers for their brilliant lectures, for their opinions. Dr. Posner, I hope you will be able to come soon to Mexico. Thank you to Christian, David, Dr. Cárdenas, Dr. Alfaro, and thank you all for joining us here. Have a nice afternoon.
Thank you.